Streaming live now. So let me check Facebook.
Good morning, Lake Highlands area moms and more against racism. We are here. My computer is tilted because my dog insists on being on my lap. He's holding the computer. Thank you, Boomer. And it is Saturday morning. Lake Highlands area moms. We are talking about healthcare this morning because it is our focus. Healthcare, racism in healthcare and disparities, inequity in healthcare. Huge topic. We're going to get it started. This morning we have Denita. Hi, Denita. Wait, and let me see here. I want to make sure we can see you. I'm going to just stop. What did I do? Did I highlight my video? Cancel spotlight. Okay, so now Denita.
Morning, everyone. Thank you all for joining us. I know it's your Saturday and we're not going to hold you long, but this is a very important topic that we want to cover. And please feel free to comment in the chat. I have my phone available, so I will read your questions and your comments for Dr. Dustin.
Hey, yeah, so I invited my husband, Dustin, here. And Dustin, I just want to share with everyone that thank you for being here. And I am so proud of you. So let me get that part out of the way first so I can say it. So Dustin is a gynecologic oncologist, which is a long word for he helps women with cancer, anything in the pelvic area. Lots of more kinds of cancer than you know down there. But also has had many years. He just delivered over 1,000 babies at Parkland, including our sweet Ellie. He delivered Ellie there. Great place to have a baby. He, 1 year did all the Dallas County rape exams. So he's had a lot of interesting experience. Now he's in private practice working with different kind of population, but still sees a variety of patients. And Dustin, I'm so proud of you. And I also appreciate the fact that you care so much about this issue and that you, it is through your work, well, our teamwork, that I'm able to do what I'm doing. So I appreciate your support in that. Say good morning.
Good morning.
So we're going to...
I should say, this is my first Zoom meeting I've ever done, even through the pandemic. I had to download Zoom just to do this.
What? Oh, and we're in the same house. It's just that we're not squeezing on the screen together. But Dustin, when you do your telemedicine chats, that's not on Zoom?
Yeah, it's on a different app that is HIPAA compliant. So patients can give authorization for it and enter stuff in a secure way.
Okay. Well, I'm happy that you've stayed safe and well during this pandemic. You're the first one of our family to get the vaccine, so that's awesome. I want to start with some general things, and I've created more slides than we'll even be able to talk about now. So I do want to encourage all our watchers and listeners to check out the YouTube playlist that we've made that has lots of videos, short ones, longer ones, about all of these issues, including just the general healthcare system, which is kind of where we're going to start today. And so let me share my screen with you. Okay, so Dr. King said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. This quote's been kind of analyzed, and people have said, actually, he said this, which is also good. Back then, he was talking about segregation in hospitals, but it's the most inhuman because it often results in physical death. And so that's why we're here. We know that is still happening and still true. I see no alternative to direct to direct action and creative nonviolence to raise the conscience of the nation. So as we talk this morning and delve into this, consider what you think direct action from our group and in your life and your circles would look like when it comes to healthcare. And what would that creative nonviolence be? We're doing that this morning just by talking about it. Health disparities are the civil rights issue of the 21st century. Denita, do you agree with that?
Absolutely.
So you know why we are here. I've got my Black Lives Matter shirt on, is to save lives. It's really why we started this group, and it's why we're doing everything. Here are just, I'm going to throw some numbers and stats at everybody so you know what we're coming from here. 265 Black people die every day in America who would not die if there were not racial disparities. And I've been reading this book that Dustin surprised me with, perfect timing, because of our focus this month, Medical Apartheid. And really it focuses on the history of racism in medicine, especially in abusing Black Americans for generations in research projects and that kind of thing. But she points out where we are right now. So you can see all these statistics. One is that's really gut-wrenching is about maternal fetal mortalities. Black babies in more racially segregated cities have higher rates of mortality. And you all should know that Dallas, it ranks 7th among segregated cities. So that's a whole other issue. And as you see, when we get into any of these issues, they all interlock, right? And they're all connected. There's just no way to separate them. But you can see all of these things, and mental illness too. So we have some videos that's certainly a part of healthcare that we need to recognize. So we have some videos about that, and we'll be posting more about that. And this last one, to me, really horrible. And that, of course, is related to gun violence too, to access to guns. But suicide rates among young Black men have soared 200%. And that was in 2006. It makes me wonder what it is now. And you saw that, I'm sorry, that Black Americans suffer highest rates of cancer and cancer deaths, and also just the diabetes rate, double that of white. So it's in everything. Dustin, do you want to comment on the cancer rates? Why do we think that's higher?
Well, you know, I can speak a little bit about gynecologic cancers, so uterine cancer, ovarian, cervical cancer. I actually had to kind of look up some of the literature, and there are differences based on the cancer type. And so, for instance, African Americans actually have fewer cases of uterine cancer than some other groups, and yet they have more deaths as a percentage due to the cancer. Some of that is access to care. Some of that is due to delays in treatments or diagnosis at more advanced stage. Some of it, there are some actual biological differences. There are several different types of uterine cancers, and the more high grade and higher risk cancers seem to be more prevalent in African American populations. In cervical cancer, it's a very different thing. The cancers are the same. It truly is an access to healthcare issue by and large. A lot of cases in minority populations are diagnosed at more advanced stage, and with more advanced stage, there's a lower chance of cure. In some of the studies, they look at, in particular, like Hispanic populations where there is, on every level, barrier to access to care, starting at basic transportation to and from hospitals, and then, insurance coverage and the use of the emergency department as their sort of point of contact with healthcare. And really at the point where they go in with a critical situation, they have an advanced stage that's likely incurable. And so, in both the Hispanic population and African-American population, we see higher death rates from cervical cancer than in a white population. And I guess I should say too, the diagnosis of cervical cancer is something that should be a rare occurrence, since we have very effective screening for it in the form of pap smears. And so, even the diagnosis indicates, potential barrier to accessing care for, appropriate screening.
Yeah, so that just brings up all these layers of health equity that starts with the culture a person is coming from. And this is what I mean by that, the social determinants. And these are all things that are influenced by systemic racist policies, right? And this is what the Poor People's Campaign and Denita work in all of these areas. And so I love this. I mean, it's a huge issue and problem, but the question to make our goal is creating a culture of good health, where healthy choice becomes an easy choice. And like you said, Dustin, if that's just from going to get your regular pap smear, Dustin, how often should women be getting pap smears?
Sorry, say it again. You cut out a little.
How often should women be getting a pap smear?
In general, it's every 3 to 5 years if they have normal pap smears. It increases in frequency if you have to have an abnormality evaluated.
And we know that in Dallas, there are free clinics to do that. Planned Parenthood is a great place to get free, what do you call them? Just screenings.
Mm-hmm.
But yes, are there places, I'm guessing like rural areas, and Denita, you would know this too, that don't offer free screenings to people?
I would say most places don't have free screening available. It may be through places like Planned Parenthood, or perhaps through like the Parkland system here in Dallas County, where there are free and low cost options. But in some places where there aren't, say, a county hospital system, and it is a system made up of physicians that see privately insured patients, there are going to be real costs associated with any screening.
So yeah, so I want to come back to that in a second. I'm pointing out the racism is happening at all these levels. So the access, the culture helps determine the general health of a population and a person. Then the access, then the treatment, and the racism is happening. The bias is happening at a treatment level that we'll talk about too. And of course, all of that leads to the disparities of the outcomes.
And also the environment.
Yeah, yes. And so definitely that's part of health. And in April, we're going to talk about that environmental racism. Let me show this quick little video that really kind of explains what we're talking about with health equity and all those components.
My grandmother tells a story of hospitals in her day, one of barriers, one of trauma, one of fear. When we are sick, she pulls remedies from a tattered notebook, recipes passed through generations of those misunderstood by the world around them. She ensures this cold, this ache, this fever will break by morning. All we need is this prayer, this herb, this belief that better days are coming. She doesn't speak of bad health. She says with stern eyes, only speak life. A lesson, a warning, and a hope in one. Packaged words birthed from a time when healthcare didn't look like help for us. I feel this chill down my spine when I am ill. When my only option left is a doctor's office or the never-ending maze of a hospital, the fear that there will be assumptions about who I am, that things will be ignored like culture and beliefs, that I won't be heard, that history repeats itself, fear that these hallways will be the same broken roads instead of bridges to new understanding. I envy those who don't have to sit with crossed fingers hoping, envy their peace of mind and comfort. All anyone wants is to be understood, to be heard, to be told that help is actually on the way.
I thought that was a really good video. Denita, you want to say anything about it?
It's exactly what we feel when we go to the doctor. I was 20 years old in college, and I had enormous stomach cramps. Had no idea where they were coming from. Had been to the emergency room twice.
Go ahead.
Been home twice from the emergency room with just ibuprofen. And I knew that there was a problem because I couldn't stand up straight. The pain was so bad. And I went back to the same emergency room again, and the same doctor, "You're back." And I was escorted out because I was labeled a drug seeker. And my pain was real pain. I mean, I'm in tears in pain. And so my roommate said, "Let's go over here to just this free clinic." And I went to the free clinic, and it was a nice little Asian doctor. And she said, "I know there's something wrong with you. I see it in your eyes. There is something wrong with you. I don't know what's wrong with you, but do you mind going to a colleague of mine? He's just right across the highway." I said, "I don't care. I just want whatever's wrong with me to be fixed." And I went to that physician, and this was the most caring, and he was a white physician, and he came in, no physical exam that I thought was happening. And he said, "What are you doing tomorrow?" And tomorrow was a Saturday. I said, "I have no plans." He said, "Well, I'm gonna schedule you for surgery." And I'm looking at him, I'm like, "Okay, you haven't touched me. Like, what do you mean surgery?" And he says, "I have to remove your gallbladder. You're jaundiced. Do you not see that?" The whites of my eyes were yellow. My nails were colored. My skin had turned. And I said, "I've been to the emergency room 3 times, and no one has said that to me. They told me to go home and take some ibuprofen, and that was it." And I had emergency surgery the next day. While in surgery, my appendix ruptured at the same time. I had, to this day, I don't know what it was, but I had something was leaking from my gallbladder. And all of that had to be cleaned out. But to have someone tell me there's nothing wrong with you, and then 3, emergency room visits later to label me as a drug seeker was just like, are you serious? I'm a student. I'm not a drug seeker. What are you talking about? And it was scary because I was away. I was in another state. I didn't have my family. And yeah, that was a horrific experience to have to go through because I knew something was wrong with me. My roommate knew something was wrong with me, and no one would believe me when I told them something was wrong with me. And you go to the doctor or the emergency room because they should know. Yeah. They're supposed to be able to, check you out to let you know what's wrong with you, or if there is something wrong with you, or to move you on to another colleague like the Asian physician did, if you can't see or tell if anything's wrong. But I had gone to that hospital 3 times, and I hadn't gotten any tests or anything.
And that was all about the bias that those doctors had. Denita, I'm so sorry you went through that, but I'm glad you told that story because, I mean, and that is the most vulnerable situation, is to be in pain or for a family member to be in pain. And so you're right. Being seen and heard and believed is such a common theme in this anti-racism work we're doing. Whether it's that someone has said something that hurts you, then as a white ally, I am to believe you when you tell me that that hurts you. Just
Absolutely.
like a doctor is to believe you when you say you're in pain.
Because at that moment, you know, even though you don't have a relationship with a physician, you trust them initially because they're a physician and that's their job and that's what they're supposed to do. And in that moment, in those 3 instances, you know, you're breaking a trust.
Yeah.
It's making it hard for the next physician who really doesn't mean me any harm
That's
to
true.
know that, you know, I believe you, I hear you. And when the physician said he was going to do surgery that next day, I cried. And he didn't know why I cried. And I told him, I said, I had been to the doctor, I had been to the emergency room, and I was told that I was a drug seeker and that there was nothing wrong with me. And for you to tell me that I need emergency surgery, I'm so relieved that there is something wrong with me.
Yes.
And it had me doubting, you know, my own symptoms and my own thoughts, because a physician was telling me that there was nothing wrong with me.
Dustin, have you seen any of that kind of just generalizations happening, or are in medical school? I'm hoping now at least they're talking about that. I know the medical community is talking about it.
Yeah. You know, I come at it kind of from the opposite end of the sort of line of doctors. So I'm almost never the first point of contact. So, you know, I'm almost always in a situation where when I see a patient as a cancer specialist, the problem has been identified and there's no question of doubt or not. So, my position is a little bit different, but certainly that is a widespread and well-known, thing that, really, a lot of patients face in emergency departments, especially if they don't have access to primary care. And if you don't have access to primary care, the only place you can go if you have acute pain or whatever is the emergency department. But they have a tally of how many times people have come in for pain. And if they come in repeatedly, then that's when they get labeled as drug seeking. And, often it is. I mean, most people aren't drug seeking. I mean, there are ways you can get pain medicine if you really need it. So, there are, well, I guess I would say, it is something that we as physicians need to be more mindful of, really listening and, really working to identify these problems.
Yeah. So I'm going to show you this. And this video, I really enjoyed watching this one. I'm not going to play it for you now, but he is identifying that problem of implicit bias. And oops, I'm going to stop. And then, but he says over 70% of Americans have an anti-Black bias. Therefore, of course, over 70% of healthcare providers have that. And so that's why it has to be addressed. So that's why all medical practices should be talking about this. So just recognizing it and then saying, okay, what do we do about it? And add the intention in those interactions, acknowledging it. So Dustin and I ran into one of his colleagues who's a member of our group, Joy Pavito. Am I saying her name correctly, Dustin? And she's an OB-GYN, and she was talking about how now when she sees a Black patient, she's a white OB-GYN female, she acknowledges it with them. And she says, hey, I know that these statistics are real about the discrepancies in Black maternal deaths and fetal deaths. And I want you to know I'm aware of it, and I am your doctor, and I'm going to do everything I can for you. And she says that people just really appreciate that, and they all come in with that knowledge. So for her to acknowledge it just helps them feel more at ease. So just even that. And then this doctor says the same thing that we have been talking about in anti-racism is in that interaction, a doctor needs to use wonder. I wonder what it was like for that person to experience that. I wonder what this person's family is like. I wonder what their home is like. Just all those things that humanize a person instead of lumping them into a category. And especially when doctors just go through so quickly, that's when that bias kicks in under those time pressure situations, the categorization of people. So just like in any of our interactions, humanizing patients and people is so important. And of course, increasing diversity among doctors is the biggest thing we can do. I'm jumping ahead a little bit here, but I want you guys to be aware of this wonderful organization, and they have a new documentary, Black Men in White Coats, and my family was all watching some of the episodes last night. They're so inspiring. And the big lesson from that is just we should be showing those images. One of the guys said they started that because he realized that people have an image of Black men. They get this reaction of being afraid. And so he said, what if instead of being afraid, we flood the internet and social media with images of Black men in white coats, and then people start to have a different response to Black men. Anyway, very, very fascinating. He was saying that he was on an airplane once, and in his hoodie, this is a guy in med school studying his chemistry book, in his hoodie, dressed like a college student, and the woman next to him said, "Are you studying to be a drug dealer?" So my Lord. Anyway, that's the categorization. And he used that phrase that I put in that slide. We need to fight the soft bigotry of low expectations. That's what that is. This idea that we see a Black male and think, they can't be a doctor, they can't have academic success. That, anyway, I just love that phrase, fight the soft bigotry. Like, maybe it's not explicit, hers was, but of low expectations, and to expect more of people, but we have to show them what they can be. So let's go back to just the general healthcare issue, because we are seeing that's the culture that is creating these people not being underinsured or uninsured. I love this quote from Dr. Paul Farmer, and Dustin and I are big fans of his from years ago. It is very expensive to give bad medical care to poor people in a rich country. And this is what our society needs to realize. Anywhere you have extreme poverty and no national health insurance, no promise of health care regardless of social standing, that's where you see the sharp limitations of market-based healthcare. Anyway, most people don't know, and my son has schooled me on this, he's very into it, that our system is one of very few that is a profit-based system. So Dustin, I will let you speak to this. What is the SGO?
The Society of Gynecologic Oncology. It's the sort of professional organization that I'm part of as a gynecologic oncologist. They really encourage research in gynecologic cancers. They have education for patients about screening and prevention, resources about treatment, and so forth. And they're also, active in promoting overall high quality cancer care across actually it's not just in the United States, but, around the world.
Yeah, so I mean, we're just pointing out that there are doctors and organizations that see that there's a problem. And Denita, I will let you speak to this. Oh, I can't hear you. Denita, can you, there you go.
Okay, so we've always talked about this interlocking injustices and how all of it, every systemic issue is related to another systemic issue. It's caused by another systemic issue. And one of the reasons, as this slide here that you're showing, is for poor and low income individuals, medical debt is the leading cause of personal bankruptcy. And so a lot of people don't want to go to the physician, especially if they're uninsured, because that's a bill that they just can't afford. An average doctor visit or a specialist visit, or even for the dentist for that matter, are extremely expensive. And what's the point of going if you can't follow up? And so a lot of treatable illnesses go untreated because of the costs that are associated with them. On this slide, you see 87 million people were uninsured or underinsured, and this was prior to the pandemic. So now you add in an additional 12 people that have lost employee provided insurance.
12 million people?
Yeah. And so these are people that have lost their jobs, and in turn, losing their jobs, they lost their health insurance. But we know the saying, people love to say, well, you have COBRA. Well, if I don't have any income, I can't afford COBRA.
Yeah.
So technically, I don't really have any insurance. And so, it's very important. I think on another, I don't know if it was with this group, Lara or not, I made the statement, corporations benefit off of state health insurance. I want to take Walmart, because everyone knows Walmart. Walmart pays their employees enough wages to be comfortable, but not enough wages to be able to afford the health insurance that they provide. Walmart employees receive 90% of state health insurance.
Whoa.
They can't afford the insurance that the company provides because of the low wages. So 90% of their employees are on state health insurance. So the state is paying to insure their workers.
So Denita, is that one of the reasons that the Poor People's Campaign is fighting for a living wage?
Yes.
Okay. So like we said, it's all connected.
It's all connected.
Yeah.
And not an incremental living wage, immediate living wage. So, politicians love to say, well, we'll get to $15 an hour by 2025 for a gradual increase. No, because guess what? The cost of living is going to go up by 2025. And that $15 will no longer be a living wage.
And the cost of living has been going up, but the living wage has not been going up. So we're far behind.
$7.25 since 2009.
Oh my God. Oh my goodness. Okay. So yeah, I mean, it's just all connected. And the pandemic has revealed so much. And I think for a lot of us, we see the problem with healthcare being connected to employment has become obvious too.
Yeah.
So Dustin, one of the reasons I wanted to have you here is because a couple weeks ago, you came home and you were, you have low days, of course, when you've had to have difficult conversations with families, but usually they can be treated at least palliatively. Sometimes you can cure them. Sometimes you can extend their lives with treatment. But I don't think people realize that there are people that fall through the cracks. Can you just mention the patient you had the other day?
Well, I had a patient, but it's something that I see with some regularity, which is, someone who is uninsured, who comes into the emergency department, usually with pain, and then is found to have metastatic cancer. And if it's a kind that I treat, then I get consulted in the hospital. And, if, there are some cancers, for instance, breast and cervical cancer are, that diagnosis actually creates an eligibility for certain Medicaid programs. And so some people will become eligible for Medicaid for treatment for that cancer. But that applies to 2 cancers out of a whole bunch. And so, for instance, I have seen patients that have uterine cancer, a different type, and that is unfortunately not one that qualifies someone for coverage. And so, if a patient comes in who lives in Dallas County, sometimes they have the option of going to Parkland. It's not automatic. There are a bunch of requirements that someone has to fulfill to be covered under the Parkland healthcare program. And included in that is, at least when I was there, I don't know if it's still the case, but a requirement was that a patient had to have no other access to insurance. And that didn't mean they just didn't have insurance. If they were offered insurance through their job, but they just couldn't afford it, then that
Walmart.
Exactly. So that disqualified them.
And
if
also
they had access through their spouse's job, and if they couldn't as a family afford an insurance plan, similarly, they were disqualified. Well, if a patient comes in and they live outside of Dallas County, if they live in a county where there is no Parkland equivalent, which is most of the surrounding counties, there's, the JPS system in Fort Worth, and there's Parkland here in Dallas County. They actually aren't eligible. And so, that's really about the toughest situation that I face, where someone comes in and, has a condition that is treatable. It may not be curable, but at least treatable. But there is no avenue for offering them treatment. That's the, and the even more tragic situation is if someone comes in from out of county and has a curable cancer, like for instance, an early stage cervical cancer. And if they don't meet the requirements, for instance, an undocumented Hispanic patient is not going to get on Medicaid. And so, that potentially curable cancer becomes a death sentence. So those are, some of the tragedies that we see, fairly routinely.
So I just don't think people realize that. I think people in Dallas kind of assume everyone can get care because we know Parkland exists.
Mm-hmm.
But there's so many people that come to Dallas for care from other places.
Yeah, I think there probably is a thought that Parkland exists and can provide coverage for essentially any patient that falls outside of the private insurance world. And it's just not the case. Just like any hospital, they have an emergency department and people can access emergency care, but that's not the same as good primary care. That doesn't take the place of routine screenings for not just cancers, but, things like, diabetes and, hypertension and all of these medical problems that can be relatively easily treated, that if treated appropriately prevent, significant complications and more costly interventions down the road.
So Dustin, what does a patient say? Are they in disbelief too when you say there aren't any options here?
Well, I'm generally not the one saying that so directly. When someone comes in like that, we have case managers in the hospital, and we have whole teams of people whose job it is to look into what coverage options exist for a patient. And, they really do a good job and leave no stone unturned, but it is sometimes the case that, those are usually the first people that, tell a patient that, we don't have an option for coverage. We always, say, you don't have to have insurance. You can, choose to pay cash if that's an option, but that's just something that's prohibitive. That'd be prohibitively expensive for me to pay for chemotherapy out of my pocket.
Yeah.
Mm-hmm.
Well, and I want to say too, we're not even talking about the insurance plans that aren't as good. There are people that might come to you and you can operate on them, but a certain hospital may not accept that insurance. And
Right.
so then they can't have what they need. I mean, there's all different kinds of variables.
There are plans out there that, for instance, allow one doctor visit per year to a primary care doctor. They don't cover specialist visits. They don't cover imaging. They don't cover surgery and hospital charges. Other plans are such, they're, just ones that don't reimburse very well. And so even if, for instance, a doctor participates in that plan, so I say this as a surgeon, it's one thing for me to have, to be contracted with an insurance carrier and be able to see a patient with that insurance in the office. But as a surgeon, if I need to do surgery, we also have to consider, is the hospital contracted with that insurance? And so there are a lot of plans that hospitals don't accept because they're such, poor payers. And so that becomes a barrier. Even people that have insurance and they think that, they've got the coverage they need might find out that the hospital system doesn't accept it.
Yeah. And I just want to say, I appreciate so much doctors like Dustin who take on patients even though they're not getting paid sometimes. But he has to have a team that does that with him. If it's surgery, he has to get an anesthesiologist willing to donate their time, and all of those things have to be in place. So as we were talking, Dustin, we were talking about, remember Sarah Palin she's the one that, I was looking this up, coined that term death panel, and it was a scare tactic to freak people out about any kind of federal system of coverage, any variety of that, because it plays into what we call the scarcity myth, which is so dangerous in all forms of resources. And that is a myth that there isn't enough power, there aren't enough resources to go around. It has to be hoarded, and that's when groups get blamed and left out and marginalized, whatever you're talking about. So in Dustin, in that patient's case, it just makes it seem like she's being sentenced, the kind of patients are being sentenced to a death panel. I mean, just because.
Yeah. The idea behind that.
Dustin, we're having trouble hearing you. Check your mic. Yeah.
Can you hear me?
Yeah.
Okay. What I was going to say was, this term death panel came about because the idea was that if you had to cover everybody, then we were going to have limited ability to provide some services, and there may be significant wait times for life-saving treatments. And effectively what would happen is a panel would have to decide, if we're going to make delays, who's going to live and who's going to die. And so, that was a scare tactic, but I think the argument could just as accurately be made that, right now, what did I say?
Just as.
Oh, yeah, more accurately be said that, we effectively have death panels now, because if we are actively choosing to not cover a whole swath of the population with access to healthcare, we are, saying that it's okay that they have higher death rates from preventable illnesses and less access to care. So, the argument can be turned around in the same way.
Yeah. And while you're talking, I'm just showing some of the stats, because there are people that say, oh, but America has the greatest healthcare system in the world, and they're afraid to lose what they have. But it's not true, right, Denita?
No, it's not true. And also, it's, again, with the narrative. The narrative is to scare people into thinking if we go to universal health care, then you're this is going to be your tax dollars, and your tax dollars are going to be paying for people that are uninsured. But guess what? People that are uninsured, they're working. So it is their tax dollars too. So it again, it's separating us by classes, by socioeconomic status, who's worthy of healthcare over who's not. Because I work a low paying job, so I'm not worthy of healthcare. So again, it's who spends the narrative.
And
Yeah,
you know,
and we end up spending more.
I was going to say too, in a county like Dallas, where we have Parkland Hospital, to some degree, you know, Parkland is funded, you know, through taxes. So, you know, we are covering, you know, some of that healthcare cost, but, you know, what we are often covering is emergency care, and it is proven to be cheaper to pay for preventative care and primary care than for emergency care.
For
Right.
sure. So we were talking about what will it take to change that? What are people afraid of? And honestly, we came to the idea that people like us are just afraid of being treated equally. We're afraid of being treated equally, and that will diminish our care, but it won't. The resources are there in our country to give the same care to everyone. And I mean, there are myths, I think, about people having to wait for life-saving surgeries in other countries, but they don't. I mean, you might have to wait a little longer for your hip replacement, but it means that someone else gets the life-saving surgery they need. And so I'm willing to do that. I mean, I don't know. There are lots of myths out there. So I think part of what we can all be doing is sharing the reality of the situation.
And also, as a country, we need to have a morality check. We seriously need to have a morality check. The selfishness that has been shown throughout this pandemic is ridiculous. We can't wear a mask because it limits, you know, people being able to hear me. We weren't able to stay indoors during the shutdown because I needed to go to the barbershop or I needed to go to the beauty salon. The pandemic has shown just how selfish as a nation we have become. And so it's all about me and my family and not so much about the next person. So I don't really care that you can't have health care.
But the pandemic has also shown people like us with our eyes open how interdependent we are on one another. So your quality of life and health makes our community stronger because it means you get to do your job, and it means your children have a supportive mother at home. I mean, it's all interdependent. So, I mean, I'm a big proponent of the idea of other people's quality of life and healthcare will build up the community. So what will it take? And like Poor People's Campaign is a moral revival. That's the message it's built on, right?
Right. Absolutely.
I am going to play this guy's little spiel because he quotes W.E. Du Bois, and he asks us, do we have the political will to show that we care? So I'm just wondering, what will it take? And he's talking about how we need stories. So after this, I'm wondering if each of you maybe has another personal or patient story to share, because I think maybe that's what it's going to take to make people feel like they're connected to it, building empathy. Can you see the screen?
There is the absence of political will to make investments.
Oh, okay. I will share my screen. Yeah, well, I mean, we've just discovered, Denita and I, in all the work we're doing, that when we share stories, it just somehow, you know, it compels people more. So the more stories, the better, I think. Okay.
There is the absence of political will, I think, to make the investments that need to be made in order to make progress. And by that I mean that just for many people who are aware of the problem, there isn't an emotional connection to it. There isn't a feeling that this is unacceptable and that we really have to mobilize to do something about it. I'll give you a statement that was made by W.E.B. Du Bois in 1899. This is a long time ago. He wrote a book called The Philadelphia Negro. In that book, he had a chapter on the health of Blacks in Philadelphia in the late 1890s. And he said one of the most difficult social problems in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. And Du Bois went on to say, there have been few other cases in the history of civilized people where human suffering has been viewed with such peculiar indifference. So it's that peculiar indifference, the absence of will to address what is in some ways an unprecedented national tragedy, I think is part of the problem. And so we need to think of ways in which we can tell the story. And I think narrative is important. So I use the word story carefully and deliberately. We need to tell the story of health equity in a way that connects with the American population, because I think we have a very compassionate and generous population, but we need to tell the story in a way that they can connect with and then be mobilized to address it. Is it?
Do you guys think that's true? Do you think we have compassionate Americans that can be compelled to care about it? You're
well,
muted.
certainly there are people who care, but you know, it's going to take a larger movement. I think you know, that's the answer right now. You know, there's just the same status quo sort of perpetuating.
I think Justin, in my delayed response to your question, Howard says a lot because we've become so aware of our surroundings and just people in general. We both should have blurted out quickly, yes, we are compassionate. There are compassionate people, but we have learned over the last several years that there's so many of us that are not. You know, there's so many of us that do not care about the next man because of, you know, varied reasons, color of skin, religion. So I think we have to address, you know, those things. Again, interlocking. Everything is, you know, tied together. Do I think it's possible? I do think it's possible. Everything starts with change. Everything starts with what's happening here on this webinar and everything. And we have to get, I don't want to say better people, but we have to get more people with morals and ethics to the table. We have to start there.
Well, and building the relationships is so important, and telling the truth is so important, and telling and sharing the stories. So your story, your personal story, the story of Dustin's patient. And Denita, did you have another story you wanted to share?
I did. It is from a friend I met in during Poor People's Campaign in Philadelphia. I went to Philadelphia to work with them to train with people in Philadelphia. And I was taken aback. They were campaigning and soliciting and trying to get petitions signed for a healthcare ombudsman. And I'm sitting here and I'm thinking, I'm like, a healthcare ombudsman, really? Like,
what's that mean?
It's really someone who advocates for the health of the patient. So the main concern is dental. Like if you, instead of, you know, a root canal or whatever other oral surgery that you need, the dentist, they're just pulling your teeth. And if pulling your teeth is not correcting the problem, then there's nothing else that they can do or nothing else that they're willing to do. And I was sharing with them because at the time I was at Baylor, and I was like, so you all don't have social worker or anything in the doctor's office to follow up with you all, or to find funding for you to have your surgery or to get the medications that you need? And she was like, no. And I was thinking, I thought that was everywhere. I thought that was everywhere. I thought all physician offices were set up like the physician office I was at. I thought that was everywhere. I found funding for infusions. I worked with pharmaceutical companies to get free medications to patients who couldn't afford it, or their insurance didn't cover it. We had a social worker in-house for the social emotional aspect of learning about your disease and dealing with your disease. And here I'm in another state, and I'm thinking it all is the same. Mm-hmm. And they're just struggling trying to get someone to advocate on their behalf because the physicians aren't listening to them. And so in this day and age, I know we've all seen the movies where everyone, the teeth are rotted out or they have no teeth. It's prevalent in this town. That's the norm, and the thought of getting dentures or what do you call it, veneers? It's far so removed from them that's not even an option. And here we are in a civilized country in the 21st century thinking of people can't even get adequate dental care from one state to another state. And yeah, it was just heartbreaking. And I'm thinking to myself, I go to the dentist twice a year. My kids go to the dentist twice a year, and you all can't get to the dentist, once. And if you go and you have a deeper issue that needs more than cleaning, they're going to take your teeth out. Like I think at the time she had a 13-year-old, and they had pulled 3 of her permanent teeth. Oh my gosh. And I'm like, your smile does something to your self-esteem. So when you can't smile because you have teeth missing, because you didn't have adequate health care to resolve an issue, that does something to you mentally. And so it was heartbreaking to see. I mean, she was a beautiful young lady. She's really talented. She's deep into Harry Potter. She did her whole room in the Harry Potter themes, and she had the hanging lights and invisible hanging lights and everything. And to see her not want to smile because she has teeth missing. It was gut-wrenching and eye-opening to the disproportionality of healthcare, not only in our country, but from state to state.
Yeah. I'm so glad you brought up dentistry, because it's the whole body. And also, like we said, we know that there are so many barriers for minorities to seek mental wellness and treatment, and that's super important. And Denita, you need to let your dog Snow in. Let the poor baby in. He wants his mommy. Okay, well, I know we're running out of time, but I want to get to really fast research. If you guys want to hang with us for a minute. And also, well, let me point this screen out. I just discovered this organization, something to look into if you're a healthcare provider, or, this is specifically for physicians, but I think it's important to point out that there are people that want this kind of coverage. So I have been reading this. Oh, and did we look at that? Yeah, look at this, you guys. Can you see it? Am I sharing my screen? No, okay. I'm going to show you why, just one example of why we're not the best country. First, I'm going to show you this because I didn't. It's called Physicians for National Health Program. And then I'm going to show you. Oh, there it is. So here's some reasons we're not even the best healthcare system. Did you know U.S. ranks number 37 in healthcare access quality? And when you look at that list, like I was looking at it yesterday, And I just kept going down and down, and I kept looking for United States, and finally I found it right above Slovenia. The US spends more on healthcare as a share of the economy, yet has the lowest life expectancy and highest suicide rates. We have the highest number of hospitalizations from preventable causes and the highest rate of avoidable deaths, and the highest chronic disease burden and obesity rate 2 times higher. Anyway, and then I wanted to show you, so medical apartheid, there's a video of her talking about this on our playlist, so you can get a little synopsis of it. But the idea is that the gap in our disparities is so big, she's calling it a medical apartheid, because it appears as if we're looking at people in 2 different countries. This is Harriet Washington. And she lays out all the research that she's done about why Black Americans often have this, is it called iatrophobia? I don't know if I'm saying that correctly, but it's a real fear of medicine. And there's this perception, there has been a perception around among a lot of healthcare providers that that's a baseless fear and a paranoia that shouldn't exist. But it exists because of this incredibly embarrassing, awful history of American doctors and government and private hospitals doing research without consent and using and abusing and exploiting Black Americans for medical research. And it started when they were slaves. It started because they were making up research to prove that enslaved people were not real people, were not the kind of people that the slave owners were. It was all made up. And it's what allowed slavery to persist for so long in our country, was this fake research, which came from tormenting slaves. Now, it's changed over the years, and she says that a lot of doctors have been afraid to, and hospitals and organizations have been afraid to acknowledge the past. We all have heard about the Tuskegee Institute. That's on there, on our playlist, but she's saying there's so much more than that. But we have to acknowledge it in order to regain the trust. So her argument is that we have to acknowledge it, and then we have to say, but we still need you to participate in research because the gaps are so huge. That's one of the ways we're going to get out of it. Participate in the research, Black Americans, but with more vigilance as to your rights and your autonomy. Dustin, can you say something about the paper, the research paper you wrote, and also maybe about that woman that we watched the video about with the HeLa cell?
Yeah, well, yeah. So that's another a fascinating story in cancer research. Henrietta Lacks, she had a cervical cancer, and when she was in the hospital, they took biopsies of this, and some of that tissue went to research labs, and it became the first set of human cancer cells that they were able to immortalize. And those cells became the sort of guinea pigs that were used to test different treatments, including the polio vaccine, and became instrumental in, I think, things like HIV medication research and other cancer research. And it was, taken without her consent, without her knowledge, without any, compensation for the millions of dollars that came from the products that were developed as a result of it. But it's stories like that. It's, the other stories of exploitation of Black patients throughout our history. Things like what happened in Nazi Germany with medical experimentation on Jewish concentration camp victims that led to a lot of the extreme scrutiny of medical research, that led to a lot of the safeguards and to the guidelines for how medical research is carried out. And so, although we have this past, we now, live in an era where research studies are very standardized, they're scrutinized through things called institutional review boards and, at a governmental level. And, we're really at a point where I think participation is as safe as it ever could possibly be. And so there has been a lot of research on participation in clinical trials, particularly broken down by racial groups as well as socioeconomic groups and so forth. And over the years, there has been a lot written about Black participation in clinical trials. We actually, when I was in training at Parkland, we looked at our experience with Parkland UT Southwestern, which basically, covered the Dallas County area, at least that hospital system. And it was encouraging to see that there were no differences in participation rates between racial groups. So I don't know what that means for the overall, national community, but it was at least encouraging that in our local area, I don't know if that means that we, had earned the trust, required to do research or not. But certainly now that I'm outside of that setting and I'm in private practice, we actually participate in clinical trials for cancer therapies. And I don't have hard numbers, but anecdotally, I would say I don't see any differences in participation rates. And so it's encouraging. I don't feel like I experience any explicit distrust. I guess that's all I have to say about it. But hopefully that is something that will be seen more widespread across the country.
Yeah, and that reminds me though of something else I think is important to bring up. When you're offering certain trials or even treatments, part of how a family chooses what to do is based on the support system for that patient. So we were talking about how certain treatments require them to come in every day for 60 minutes for radiation, and how some families just can't do that. They don't have the transportation, can't get off work, don't have the childcare. So those are just all factors that for us to think about.
Yeah, not even just related to research, but just standard of care treatments sometimes can be very burdensome in terms of taking off of work, of getting transportation. A lot of times the treatments require medications that can make you drowsy, and so you're not safe to drive home, so you actually have to have somebody transport you to and from, so that becomes another barrier.
So we talked about Dustin, you mentioned there's an organization that does offer rides. I know there's an organization at Parkland that offers childcare. I think one in private hospitals too, some places. Anyway, just look for those, make sure people know about those as a friend out there, as physicians and nurses. But it's a big problem, but it's something we can all do something about. I think whether we're the patient, whether we're someone that's uncovered, undercovered, and we're voters, and we can direct policy and we can share stories. Denita, what else do you want to say?
I just want to say, if we could just go back to being community. I remember visiting my grandmother during the summer, and she would take people to doctor's appointments because their children were at work or their spouse was at work. She would watch after the kids if someone had to go to a physician's appointment or just had to run errands. There's nothing wrong with going back to that because it worked. It worked. Now we're so stuck in, I know so many people who don't even know their neighbors. We're so wrapped up in our own selves that we forget about, what community is, what it was, and we've all experienced it growing up. So I love the idea of community. I love knowing my neighbor.
You're my beloved community.
You know, and I know, I have my kids and I, we're huge within ourselves. But the fact that I can lift the load of a young mom and assist her when needed, that's the sense of community that we need to be trying to get back to. It doesn't take much. It doesn't take much. I mean, and that all comes back to, we got to get back to having morals. We got to get back to having morals. What kind of person would I be if I sit here and I pass judgment on this young lady and see she's struggling without reaching out to lend a helping hand? And I'm trying to convince other people to be, the catalyst for change, but I can't change myself. So that's my thing. I would love for people to get back to a sense of community and stop passing judgment on just people, period. We're all going through things, whether it's seen or unseen, and just being someone there.
Yeah. That's why I love, Denita, that we've built this beloved community together. And whether it's healthcare or education or any of these areas that we delve into, everyone can find a way to become an activist and an advocate for those who are less fortunate and less privileged. If you have any place of privilege or power, there is a way for you to use that and take action. Dustin, do you have any what I would want to ask you for your final comment, Dustin, maybe is, if this is Denita's question. Oh, Denita, you ask your question.
Oh, I don't know if you've heard Larry talk about it, but you have this magic wand. And with your magic wand in your profession of healthcare, what would you change? And it's an immediate change. It's not gradual.
Well, it's so tough because, as you said, everything is interconnected. And so, on the one hand, I think probably the easiest thing to say would be, for everybody to have access to good quality healthcare. I think that's probably the easiest thing to say, but there are so many levels to it. If we're operating in the same setting that we are, then it has to be everybody has access to jobs to get their insurance. And if everybody has to have access to jobs, then they have to have access to education. And then, it's just so many layers of needs. But if I could change one thing about, my world in healthcare, it would just be that everybody had access to good quality healthcare.
Yeah. And I would say, honey, to everybody has access to a kind, caring, empathetic doctor like you. You're awesome. It's true. Thank you so much. And I have to say, he's gotten awards from his patients for being a top voted doctor by his patients. So that's so awesome. But you, Dustin, you, Denita, you watchers out there, keep making good trouble in healthcare. Watch some of these videos when you can that are on our YouTube playlist to learn a little more. And what they do is give you some words and vocabulary to use when you're out in your circles talking with other people about this issue. And
can I pause for 1 second? maybe we should ask the question from the other end, as someone in healthcare, to Denita, if you could change one thing about the healthcare system, what would you do? What would you have us do? What would be the best change from your perspective?
I think what I would change is not attaching healthcare to income. Whether you have a job or you have Medicaid, not attaching it to your income, because healthcare is who we are. I mean, without healthcare, if I'm sick, I can't go to work. If I'm sick, there's no treatment I can get. So not attaching any healthcare to a job or to your income would be what I would want to change.
I agree. And like you said at the beginning, Denita, also just having a place to feel seen and heard and believed. That's so important. Well, there's lots happened here today. It's such an important issue, and I'm happy that you all are both healthy and well and have stayed well, and our families have stayed well, and we wish health and wellness to everyone out there watching. And keep making good trouble. I love seeing all the comments coming in, so keep the conversation going on our comment thread, and we'll post this also to our YouTube playlist.
And also, Dustin mentioned Henrietta Lacks. If you have no idea who she is, please read her story. It is
She's on our playlist too. She's on our playlist.
Fascinating story, and there is a documentary with regards to it. And just the family has been compensated. It took years for that to happen.
Like 60 years.
But it finally happened, and so that's an awesome story to read. I was taken aback reading her story. So, and it is on Amazon. So,
yay! Okay, I love you both. You're awesome.
Awesome, guys. Enjoy your Saturday.
Okay, bye, sister. Yeah, it's Saturday. Thank you, Dustin. See you in a minute.
All right, bye.